Albert and his class, they joined as attendees, and I think we can begin now. So as a short introduction, on behalf of Health for the World, good morning to everyone that has joined for today's internal medicine grant rounds. Today we have Dr. Vidya Sundareshan. Dr. Sundareshan is a professor and chief of infectious disease in Southern Illinois University. She completed her medical degree at Ambedkar Medical College in India and continued her internal medicine residency in Southern Illinois University, and then completed her infectious disease fellowship at that same institution. Dr. Sundareshan also serves as the program director for infectious disease fellowship. Without further ado, Dr. Sundareshan, please.
Thank you very much, Dr. Montez, and I'm very excited to talk to the medical resident group from Ethiopia, and this is really an honor to be able to share some of the information that about wound care specifically that will be on the Health for the World website as well. So thank you very much again for this opportunity to the organization, as well as Dr. Prakash who, from SIU, who has helped coordinate this. All right, I will talk a little bit about the pathology of wounds, management of chronic wounds using a comprehensive approach, a stepwise approach, and then we will be using diabetic foot infections as a prototype as we walk through this algorithm of wound care management. What is a wound? We'll start with something very basic. So skin is the largest organ we have, very, very useful because it helps us protect from all the onslaught of the weather, anything, all kinds of onslaught. It helps us, it helps protect us. Any disruption in the normal structure and function of the skin and skin architecture is a wound. It can be an acute wound or a chronic wound. So an acute wound, the timing, although they say any wound that has been present for more than 4 weeks or for 2 weeks in diabetics classifies as a chronic wound, we really don't adhere to this timing per se. Acute wounds are wounds with almost a normal pathology, normal physiology, and they heal well. With chronic wounds, the healing process is impaired and there's some physiological impairment. Before we go into the pathophys, I would like to talk a little bit about chronic wound epidemiology. So more than 6 million Americans here suffer from chronic wounds. Over 1 million cases of chronic wounds, new chronic wounds, new cases each year are seen in wound care settings and other settings, in the outpatient settings, inpatient settings. 3.5% of the Americans over 65 years have venous ulcers, and over 1 million Americans suffer from pressure ulcers. And there's a 25% lifetime risk of development of ulcers in about 18 million Americans with diabetes. So wounds are a part of patient care when you see them in the hospital, when you see them in outpatient settings. When you see these wounds, they have to be addressed and treated appropriately. With the etiology of chronic wounds, diabetics, there's about 26% of the wounds seen with diabetic wounds, arterial wounds 21%, venous 18%, pressure ulcers 16%. So those are the bulk of what we see. Surgical wounds about 6%, burns about 3%, especially if you have a burn center, then you end up seeing a lot more. And trauma, wounds associated with traumas, ostomy wounds, other wounds from you see in people with accidents or injuries, those constitute about 4%. Not only is it a problem with morbidity, but there is also a relative 5-year mortality rate associated with these wounds, which is shown in this slide. So coming to the pathophysiology with wound healing, the normal process has a homeostasis process followed by an inflammatory phase, then a proliferative phase, and a remodeling phase. And those can be impaired. For instance, somebody with arterial disease, peripheral arterial disease, there's hypoxia. So any of these stages can actually be impaired. Mainly what you see is in the inflammation stage, when that is overly prolonged with a disarrayed response from neutrophils, macrophages, mast cells, all that kind of constitutes a delayed wound healing and leading to chronic wounds. Actually speaking, this can occur in any stage of wound healing, the prolongation there, but mainly in the inflammatory process, but it can occur in any other process that we had mentioned earlier, the proliferative phase, the remodeling phase, and the homeostasis as well. I've shown also in this picture, when wounds heal by first primary intention or secondary intention or a third intention, when the size of the wound and the granulation determines what kind of a healing process is going to occur, and also whether there's going to be healing with scarring, how much of that scarring is going to occur, whether there's epithelium that grows over the scar, whether this is going to lead to a big scar. All these are different outcomes associated with wounds. So I'll jump right into management of patients with wounds. These are some algorithms which I borrowed from wound care, and we typically follow a stepwise approach. And when you do that, you will not go wrong in identifying the type of wound, and also not go wrong in giving the right kind of treatment for these wounds. So is there a wound? Yes. So you want to get a complete history and the origin of the wound to begin with. That's your first step. So a timed approach. So you want to look at what tests were previously performed. What were the influencing factors? What made the wound better? What made the wound worse? Any treatments? Were the patients given any treatment prior to you seeing the patient? Get a list of all those. What do you think is the etiology? And I'll tell you more about how to identify that, and how long has the wound been there. So these are the basic things about wounds in the history aspect that we definitely need to get. Location is key. Step 2, you want to know and try to make an assessment of the diagnosis by location. If you see a wound in the medial malleolus or the lateral malleolus areas, you think of venous wounds. So the diagnosis can be guided a lot by the location of the wound. So leg ulcerations mostly are vascular. So 70 to 80% of those being venous ulcers. Arterial ulcers, you want to look for a history of atherosclerosis. You want to see if there are any emboli present. You want to rule out vasculitis, coagulopathy, small vessel disease. These are some of the things that you want to rule out with any arterial ulcers. And arterial ulcers or arterial wounds, see at the tip of the fingers or toes, and you'll see the wounds more in the distal part of the limbs. Lymphatics, if there is any associated problem with lymphatics, you see lymphedema. So the whole limb is swollen. And I'll show you pictures of that as well later. So this is an example of an arterial wound. So more distally, more in the tips of the toes. Neuropathic ulcers or neuropathic wounds that with diabetes, you see that spinal cord injury, tabes dorsalis, syphilis, and any condition which is associated with a decreased sensation, you see neuropathic wounds. Non-vascular pressure wounds are top there, and patients who are not able to have good motor strength, they're debilitated, lying in bed for a long time. So pressure wounds you see often in these patients. burns, cold with frostbite, spider bites. You can see pressure wounds associated with these as well. So some of the characteristics of pressure-induced injuries. So it is usually located over bony prominences, including medial lateral metatarsal heads over the calcaneus, where the foot is just lying on the bed, unable to move, ischial tuberosities, a fibular head, sacrum. There's fibrotic tissue usually and causing this necrotic eschar, this black appearing tissue there. And that needs to be debrided. That's one indication for the wound to undergo debridement. Deep probing to the level of the bone and undermining of skin. When we say undermining, the edges are kind of overhanging. You see that typically with the pressure ulcers. And then surrounding that wound, if you palpate, you'll see a little bit of edema. You'll also see a peri-wound. Around the wound area, there is erythema. Anytime there is a wound below the inguinal ligament, then you want to get a vascular assessment. You want to definitely make sure that that is not the cause for the wound that you're seeing. So when you see a patient get a Doppler, this is a must for any clinic that assesses patients with wounds. In fact, it should be a must in every clinic. You can't always feel the Doppler by physical examination. You can't feel the pulse by physical examination all the time. So Doppler is very useful in situations like that. On the other side, I've shown you transcutaneous oxygen measurement, a machine that can get that. Not used as much now because the sensitivity of these machines can vary. The best is Doppler. You should at least have that basic amenity in your clinics when you're assessing wounds. All right, so we went over this algorithm. We got a complete history and we got a good review of systems for the patients. We were able to determine the location of the wounds. We were able to get some vascular assessments. And the next would be to identify a common pathway. Before that, a physical examination, look at the hair, skin, nails. In diabetic patients, you want to look for wounds like necrobiosis, lipodermatosclerosis. And these would be typical when you ask them for a history of diabetes. You identify these wounds, go back and ask for a history of diabetes. Get a calf circumference. When you get a calf circumference, these are helpful for a peripheral vascular disease and also venous diseases. When there is edema, you want to assess for that. So these are very useful for that. Pain helps you identify a lot of things. In fact, when there's a wound associated with pain, you want to make sure there's no infection. It's one of the cardinal signs for infection. And necrosis. If there's any necrosis, then you want to make sure that the patient is taken to someone who can debride that wound, a surgical approach, or you can do that in the office if you're comfortable. Pulse examination, like we said, we definitely have to do that with the Doppler. All right. You want to next measure the wound. So get the size of the wound, characteristics of the wound when you assess. You want to look at the exudate. What kind of exudate is it? Is it a serous exudate? Is it a serous sanguineous one? Is it a seropurulent one? Is it a purulent exudate? You want to make an assessment of the exudate. You want to look at the appearance of the wound bed. That's very important. How much of the wound is actually granulated? Is there a lot of slough? Do I need to debride this? Is there pain? When I say suffering, that's pain. Undermining, again, that will help you determine whether there is an element of pressure. Also, how is the wound healing? If there's a lot of undermining, you want to debride the edges as well, so the wound starts to heal better. And then definitely you need to follow these patients on a regular basis. In fact, photographing these wounds has shown to help as you see the evolution because of the inter-evaluator variability and also intra-evaluator variability. It's always good to have objective measurements of what the wound looks like. And if you're getting pictures with serial visits, you can do a better job of assessing that. The edges of the wounds give a lot of information. Pyoderma gangrenosum, that's one of the areas where you want to go for a biopsy. So look at the edge of the wound, and any venous ulcers. What does the edge look like? Is it kind of accumulating and becoming thick? Does this need a biopsy? So those decisions you'll definitely be able to make with a good evaluation of the wound. Okay, and then when you're getting an assessment done, you also want to get a culture, send it for histopathology when needed, blood work, any associated blood work, and diagnostic radiology if there is a need at that point, a concern for osteomyelitis, concern for any deeper extension of the infection, you definitely want to do that. And comorbidities, EKG, chest X-ray, any clinical consultation that's needed for the patient. And that kind of kicks into the final common pathway for the patient. So you want to look at the patient as a whole. It's not just the wound. So once you're assessed, once you have assessed and gotten a fair idea, to make sure that you are instituting a good therapeutic regimen for the patient, you want to make sure that you are assessing the patient as a whole. So make sure there's no infection, there's no malperfusion or hypoxia, there's no cellular failure, there's no unrelieved pressure, trauma, pathological inflammation, chronic inflammation in this patient, and all the comorbidities that you want to address in this patient. Diabetes, renal dysfunction, ischemic heart disease, is the patient a smoker, is the patient malnourished, all those you definitely want to get information on and address when you're taking care of these patients. I'll dive into the therapeutic principles, again, a stepwise approach. And this is very important because if you don't do one, you may be actually not treating the patient correctly, because let's say you're not addressing the perfusion and oxygenation part, and you are identifying an infection and you're giving antibiotic after antibiotic after antibiotic, but the wound is not going to heal unless you actually address the perfusion issue. So the stepwise principle is also important to be able to be organized in the way that you're treating this patient and not miss anything. And secondly, if it's done in the order that is actually prescribed, you will not make mistakes. If there is a arterial issue and you are applying compression to this patient's limb, you may not be doing the right thing. So the first and foremost thing you want to do is assess if there's adequate perfusion or oxygenation. Next, you want to see if there's any non-viable tissue present in that wound. If there's any non-viable tissue, you want to make sure that that's debrided and taken care of. Third would be to look for any signs and symptoms of infection and inflammation, tubercle or dolor, all your things that you learned in pathology on how to identify infection, inflammation. Those are the things that you want to look for in a wound. Next, after that, you see if there's any edema. If there's any edema, then if your perfusion is good, yes, by all means, you are not going to heal this patient with antibiotics again. Even if you keep prolonging antibiotics, you shouldn't do that. If there's edema, then application of compression is the way to heal that wound. And then microenvironment, conducive to healing. Our nurses do a very nice job of this when they do dressings for our patients with wounds. The microenvironment has to be something that helps to heal. If it's a dry wound, then you apply any dressing which will take care of that dryness. If it's a wound that's oozing continuously, then you want to have a dressing which is going to absorb that exudate and allow that wound to heal. So those are some of the things that you can take care of when I refer to microenvironment. That's what I'm talking about. Is tissue growth optimized? Sometimes the skin is just too sluggish. It's not growing. The wound is not healing. What can you do? Of course, helping with that debridement and making sure that the granulation tissue is rich and it's fresh, and it's healthy. That will help with the tissue growth. But sometimes you need to apply some kind of a bioengineered graft. So those modalities are also available, and you want to assess when it is a good time to be able to do that. Offloading, when you have pressure wounds, pressure ulcers, you want to make sure that there's adequate offloading. You don't want to keep adding salt to injury there. So you want to make sure there's adequate offloading for these patients. And then, is pain well controlled? Pain, like I said, is a cardinal sign also of infection, but also you want to make sure that the pain is well controlled, as well as host factors optimization. So those are the steps that you want to take care of and address. We already talked about circulation. So macro circulation, you also want to get a arteriobrachial index or tibial brachial index. These will give you an assessment, and again, non-invasive and a good measure of what's going on in terms of circulation for the patient. And then pulse, like we said, we want to get that in the clinic as well. For microcirculations, the transcutaneous oxygenation monitoring, the picture that's shown there, it's costly. It takes about 30 minutes, the procedure, and you don't get so much information. So a lot of the clinics now have moved away from doing this. Skin perfusion pressure. This is again like a ABI, but it's a blood pressure cuff, kind of a machine there with a laser Doppler probe that's already in that inflatable cuff there. So that's specific for peripheral arterial disease, and that's more sensitive. All right. So ABIs, Doppler waveforms, segmental limb pressures, pulse volume recordings, TBI, plethysmography, and then ankle pressures, exercise ABI. These are some of the things that a specific or specialized vascular lab can perform. So here's how the ABI is performed. You get the blood pressure in the arms, you get the blood pressure in the legs, and then you express that as a ratio, and you see where it falls. If it is 1, it's good. It's 0.91 to 0.99. There's borderline. 0.41 to 0.90. Mild to moderate peripheral arterial disease. And then if it's 0 to 0.4, then severe peripheral arterial disease there. Again, I put this picture 3 times because it's very important to have this in your clinical setup. If you're not able to find the pulse, use a Doppler. Use a Doppler to find the pulse. ABI is a screening test. This kind of compares it with pap smear and fecal occult blood testing, mammograms. So sensitivity is very high, and look at the specificity, it's 100%. So when available, definitely utilize those. I want to say that sometimes we see this wound and you're really sure there's a big problem there. Patient's diabetic, you know that there's going to be a problem with their perfusion, and you see a good ABI that may be due to calcified vessels in diabetics, renal failure in elderly patients. So calcified vessels can spuriously give you a high ABI, although that necessarily does not mean that the patient has good perfusion. And then normal ABI, there's, again, with patients with IO2 iliac disease may have normal ABIs, but exercise will cause that pressure to drop. So some specialized tests with the help of your vascular colleagues may be useful there. Now, remember that we're kind of moving away from big surgeries for vascular. We have revascularization procedures, which can be done actually by, it's just like a cardiac cath. You can put stents in the vessels of the legs, different levels. You can choose the larger vessels, smaller vessels, down to the vessels in the ankles. These are so specialized now with angioplasty, and there's vascular specialists who can do this. So this is definitely very helpful for patients with arterial disease, and it's not as invasive as large surgeries, bypass surgeries that we are performing, and the results are fairly good. All right, so venous ulcers, like I was telling you earlier, medial lateral malleolus with those ulcers. You want to identify those by the location. Also look at the skin discoloration that this patient has with venous stasis, etc. So some of the physical exam characteristics which will help you identify a venous ulcer. They can get infected. You can see these develop into malignancy. So you want to monitor them carefully. Compression is a big thing in the management of these venous ulcers. Different types of compressions. You can get a Una boot with a zinc lining for these compressions. So 2-layer wrap, 4-layer wrap, and different types of compression devices that can help with the venous ulcers. I can tell you a story of when I first started wound care. I used to think that antibiotics will help these ulcers, and I used to give a lot of antibiotics to these patients, and I realized it never helped. Then the nurse who I worked with was very experienced in wound care, and she said, "Doctor, this is a venous ulcer, this needs compression." So yes, we added compression. Next week, the wound started getting smaller. So, remember that once you identify the cause, you treat it correctly, you can heal the wounds. And again, venous hypertension. A lot of these patients with venous diseases have venous hypertension. So you can see the picture here with the normal blood flow there and the valves, which are dysfunctional. See what the blood flow is there. There's retrograde flow there, and then you're getting a lot of swelling in the legs because of this. So compression definitely is helpful in situations like that. With varicose veins, so this classification and categorization helps to also classify how bad the varicosities are. This is more so for vascular specialists. And telangiectasias, these are some of the things that can help you identify that the classification there. And then bad varicose veins. There are vascular medicine people who can help with that. And they, to a certain degree, do help with wound healing as well. So here again, discoloration of the limbs with venous ulcers there. And see how heaped up the edges are here. This is one of the wounds where I would definitely get a biopsy there if the wound has been there for a long time. Next, I'd go to debridement. You can do sharp surgical debridement, non-selective, where you're removing the non-migratory and old cells. So the newer cells, you've got these reactive oxygen species, which will help with the healing. And also, you have all these new blood vessels, which are helping with the healing process. So debridement is very helpful when you're removing that non-viable tissue. That's a very important part of wound management. And also, if there's any infection, the bacterial load comes down, and biofilm. Bacteria produce biofilm, and when you're removing that mechanically, that really helps with the debridement. That biofilm also comes off, and the bioburden comes down. So you're helping in many ways when you're debriding a wound. which you make sure that the perfusion is good. The next step would be to make to see how you can help it heal faster. All right. So, and then like I was saying, the endogenous growth factors are kind of flowing in every time you're debriding there, and controlling pathology with the bacterial bioburden. If there is any infection, so pathology is also controlled. So a lot of advantages there with the debridement. This is the kind of wounds that I would definitely debride. If there's an eschar, you want to see how deep this wound is. That eschar is covering everything. You can't stage it at all. Sometimes, the location of this eschar and the size, plastic surgeons make a determination going by, if the patient's on Coumadin, or any kind of a blood thinner, will that help? They make a decision and determination of the timing, etc., for the surgery. But eschars, the debridement will definitely help. You can debride also by, it doesn't always have to be mechanical. The wound in the bottom is covered with slough. So slough is all this exudate, which is kind of solidifying there and collecting there. And you want to liquefy that so you can remove it. So you have enzymatic debridement. There are ointments or creams which are rich in enzymes, and once you apply that to the wound, it starts to liquefy this slough. So that comes off easily. The next time the patient's there, you don't even have to take a scalpel to the wound. Sometimes just a gauze, if you kind of just clean the wound with a gauze that with those enzymatic debriders, it actually comes off. So biologic debriders, people have used maggots, etc., for debridement as well. That, I don't know. I mean, that has some, it can be associated with infections with maggot therapy, etc. But gram-negative infections. So. You want to see who's really eligible for that surgical debridement. If it's a large wound, get surgery involved. And then if it's a smaller wound with a lot of slough, you can do that safely in the wound clinics. Mechanical debridement, enzymatic debridements are very, very popular means of doing that. Okay, so infection is the next thing that I'm going to talk about. So all wounds have some kind of microbes that colonize. Not all wounds are infected. So make that determination. That's very useful to make that determination. I'll show you in the next slide what that paradigm kind of looks like. Antibiotic therapy is not indicated for all wounds. Use them prudently. Antibiotics are very helpful, but our stewardship for antibiotics is just equally important. You want to make sure that you're not using antibiotics unnecessarily for wounds that don't need antibiotics. So look for the cardinal signs of infections. If there's a lot of purulence, there's redness, erythema, a surgical site, you're looking at that it's really red, there's cellulitis. Those are some of the things which should tip you off. And systemic symptoms, look for any systemic symptoms. If the patient has fevers, chills, nausea, hypotension, of course you want to give them antibiotics in situations like that. All right, so I want to go over some terms: wound contamination, colonization, critical colonization, wound infection, and then advanced wound infection. So you see that gradation there. So there are bacteria present in wounds, especially if if the dressing has been there for a long time, if somebody has a wound back, and you want to be careful about what you're culturing. So you debride and then culture, you're getting a better assessment of what's really causing the pathology. If you're just going with surface cultures without cleaning the wound, there's only about a 10% to 20% correlation of what's actually causing the infection. So make sure you get the right kind of cultures there. And then also with the colonizations, wounds can be colonized. So you don't want to be treating colonization. If there's colonization with Staph aureus, Enterococcus, those are some really uh, bad bugs, and if you're going to start treating colonization, we're in trouble. So you want to make sure there's a true infection before treating these wounds. The exudates, so here serous, serosanguinous, seropurulent, and purulent exudates. You can tell by the color, and then also the way the wounds look with the infection. Edema, again, a calf muscle is a pump there. A lot of the people with venous diseases have lost that function. So giving them, devices to help with the edema is definitely very useful. So a chronic venous insufficiency, you want to use compression. Lymphedema, you want to use a compression. You can see the different presentations there and different devices that you can use for the compression there. Just wanted to talk a little bit about stages of lymphedema. So stage 3 it was what you saw there in the picture there. Actually, that was lipedema, but lymphedema stage 3 kind of looks like that too, with elephantiasis. So these patients, you want to definitely do compression therapy with lymphedema. Specifically, the manual lymphatic drainage can be very helpful. Exercise is very, very useful in these patients, and skincare. A lot of them, they develop cellulitis without proper skincare. There can be infection, and then DVTs is also another risk. Different types of compression devices here. Compression stockings, you can see that stockings are not good for everyone. It's hard to put on. So there's that device there, that little stand, which will help people put those stockings on. And also, some people feel better with Velcro or other compression wraps. That's easier to put on, nighttime garments, etc., which can be used. Talked about using the right microenvironment for wounds. So different dressings which are available. Nurses do a great job with this, and yeah, it's worthwhile looking at what kind of dressings will be useful for the patient. The main principle here is, if your wound is dry, use a dressing which will give moisture to the wound. If your wound is exuding a lot, has a lot of exudates there, then you use something that will absorb that dressing. Here I've included some dressings which also have antimicrobial actions, something with iodine, silver that has an antimicrobial. It may not be antibiotic, but it definitely helps with critical colonization in the wounds where the bioburden is helped with these kind of dressings if they're incorporated. We talked about the bioengineered grafts. So Apligraft, Dermagraft, Epifix, these are some of the grafts that people can use. And also negative pressure wound therapy, which has really revolutionized the way wounds are managed with just sponge and then application of negative pressure to that wound helps that wound come together and close. So large wounds, you see wound vac or negative pressure wound therapy, which is really helpful for patients. Quickly delving into diabetic foot infections and using that as a prototype. It is a big problem, lifetime risk for foot ulcers in diabetics as high as 34%. So this is a problem with, again, like we spoke earlier, associated with morbidity and mortality there. So significant morbidity, significant mortality there. So you want to make this a routine part of management of your patients with diabetics, to look at their feet, look for any wounds. And what I'm going over right now is Infectious Diseases Society of America. They have really good guidelines for diabetic foot infections. This was published in 2012 and recently updated too. So what they talk about is identification of infections. How do you assess these? Who needs a consultation? And who do I hospitalize when I find patients with diabetic foot infections? How do you obtain cultures? What antibiotics to choose? Who needs imaging? How do I diagnose osteomyelitis? And what kind of surgeries are preferred for these patients? and any specific wound care techniques. So diabetic foot infections require attention to local as well as systemic issues in a coordinated fashion, preferably by a multidisciplinary foot care team, sorry. And then the team managing these infections should include an infectious diseases specialist or a medical microbiologist. There are different bacteria that can cause these infections, mainly gram-positive, the skin and soft tissue kind of infections. And then we always tell our learners, think of diabetic foot infections to be polymicrobial. So cover for gram-negative organisms like Pseudomonas and also anaerobes. When the wound is smelling bad, think of anaerobes. When you go into the room, this wound is smelling bad, you have to think of anaerobes. Diabetic infections are polymicrobial. A lot of them have anaerobic infections. Typical the microbiological spectrum could differ by geographic location as well. So this study from India looked at what is the most common etiology there in terms of pathogenic bacteria, and they found that unlike what we find here in the US, which is mainly gram-positive infections, gram-negative infections actually predominated in India. So look at your local antibiogram, look at what these susceptibilities of these bacteria look like, and also look at what you're finding there. And then you could use presumptive or empiric antibiotics based on that. All right. And again, when you're looking at infections, you want to look at the local signs as well as the systemic signs of infection and inflammation. So rubor, cholar, dolar, etc. And then you also want to look at the labs to make a determination. IDSA gives this really nice infection severity scale. So no signs of infection, no symptoms, uninfected, to all the way severe in their infection severity scale, where the blood pressure is dropping, the patient has a fever, has all the signs of sepsis there. So they've categorized that based on the severity and how the management should be. This is also an important classification. You'll see this. This is a classification by Wagner. And it talks about how the blood vessels are actually involved, or how much of arterial disease is associated with diabetic foot infection presentation there. So grade 0 is no ulcer, grade 1 superficial ulcer, grade 2 deep ulcer penetrating down to the ligaments. This is what we usually see, grade 2 and above when they present for care. Grade 3 is deep ulcer with cellulitis. Grade 4, there's local gangrene. And then grade 5, there's extensive gangrene, and you cannot salvage that foot anymore. So some of the things you want to do: debridement, infection control with the antibiotics, local wound care, mechanical offloading. Again, this is just like a pressure ulcer in these patients too. So you want to offload from that ulcer. You can apply a total contact cast, so they're not putting pressure on that wound all the time and not walking on that ulcer. They're knee walkers or therapeutic shoes, which are really important for management of our patients with diabetes. So the grade lesions, like we were telling you, you want to assess for vascular disease and osteomyelitis. If the wound is deeper, if the ulcer is deeper, then you definitely want to look for osteomyelitis. And then finally, grade 5, if these are really advanced lesions, then you want to get them to the hospital. Surgical consultation and amputation may be needed if the wounds are not looking good and there's arterial supply is not good. Cultures need to be sent. We base a lot of our treatment on the definitive diagnosis or the definitive cultures, microbiological diagnosis from intraoperative cultures that we get. Who do you want to get imaging in? These may be helpful to diagnose better when the soft tissue is kind of compromised to a great extent. You're able to probe deep down to the bone. Getting an MRI is very useful in these patients to rule out osteomyelitis, even early osteomyelitis, which may not need such strong surgical interventions. But again, source control is important. If you have a larger abscess, then you can't treat that with antibiotics alone. So in those situations, you want a combination of surgery as well as antibiotics there. All right, so antibiotic therapy is important. A lot of times we end up giving these patients IV antibiotics. Broad spectrum empiric antibiotic is not routinely required because a lot of them are not typically very sick when they're coming into the hospital. You can hold off for antibiotics till the culture is taken. So unless they're septic, if they're septic, then do not hold the antibiotics in that situation. These are some presumptive antibiotic choices. Broad spectrum, you can use piperacillin tazobactam, you can use cefepime, you can use a quinolone if they don't have any contraindications. If they have a penicillin allergy, then a monobactam like aztreonam can be used. And compare that and pair that with a gram-positive coverage antibiotic like vancomycin, daptomycin, linezolid, etc. For mild infections, you can get biwood treatment for 1 to 2 weeks. If there's osteomyelitis, then the treatment lasts for about 4 to 6 weeks. It need not all be intravenous. You can give 1 to 2 weeks of intravenous therapy followed by oral antibiotics, especially if there's not much arterial involvement, there's no PAD in those situations. You can definitely get by with oral antibiotic tail with an initial IV antibiotics that are given to the patient. And surgical consultation, if you have a deep abscess, extensive bone involvement, crepitus, necrosis, gangrene, necrotizing fasciitis, these are all indications for surgical debridement. Persistent sepsis without an alternate source, progressive bone deterioration, and the patient's not doing well, then surgery will be helpful. A word about follow-up with hyperbaric oxygen. Patients who have been discharged, seen in wound clinic, we use hyperbaric oxygen. That's a chamber, that's a monoplace chamber that you're seeing. That patient is going to be going into that chamber. There's a nurse right there who'll sit there. There's a tech who manages these and looks at these patients regularly to make sure that they're doing well. They're not seizing, their blood sugars can drop when they're in these oxygen chambers, the hyperbaric oxygen chambers. So they are monitored while they're there. Somebody's there all the time. This is something which is diabetic foot infections are approved for hyperbaric chambers. Medicaid will pay for that here. We consider this in a lot of patients, but a lot of the countries, hyperbaric chambers or use of hyperbaric oxygen, the data is really plus minus. A lot of people don't really strongly believe, it's not part of their wound care paradigm and their algorithm. But here, a lot of the wound centers are equipped with that. All right, and then lastly, with the bioengineered grafts, etc. So you'll see that you can apply these extra grafts, and then again, those are helpful as well. And if there's osteomyelitis, like I said, the debridement has to be done by the surgeon here. Okay. I'm sorry. Yeah. So just to summarize here, that you want to take care of hypoglycemia when you're taking care of the patient in totality. Make sure you do a vascular assessment. Make sure you get an MRI if you're thinking of osteomyelitis there. And local wound care is very, very important. If there's infections, you want to start presumptive antibiotics if the patient is septic. Otherwise, you can hold off on antibiotics, switch from a parenteral to an oral regimen when you can. You don't need to continue the parenteral regimen for all of the 6 weeks that you're giving the antibiotics. And again, for chronic wounds, these are physiologically impaired wounds. The healing is impaired in any of those stages that we talked about: hemostasis, inflammation, fibrosis, etc. And then for management of these patients, get a complete history, do a vascular assessment, and follow those comprehensive stepwise approach for wound care, which will definitely be helpful for the patients. And again, look at the patients in totality. If they have comorbidities, they need to be taken care of. Wound photography is helpful in wound clinics, and many of the wound clinics are multidisciplinary. So you have a surgeon there, you have an infectious diseases physician, a vascular medicine person or vascular surgeon, podiatrist. A lot of this management of wounds is multidisciplinary. So try to use the expertise of your colleagues who can help you with taking care of these complicated patients. I will stop right here. I want to save about 10 minutes for questions. So sorry, I rushed through the last couple of slides, but just wanted to make sure there's enough time for questions there.
Dr. Sundareshan, thank you so much for the comprehensive lecture. It seems like we don't have any questions from the audience, but thank you so much for this super enlightening. And yeah, definitely, this is definitely something that requires multidisciplinary approach. I think you're muted.
Yeah, thank you very much. You know, I want to just leave with a comment that geographically, when you're treating wounds, it varies, depends on where you are. Epidemiology is very, very important. So, you know, what you find in Africa, let's say there are some ulcers, mycobacterial infections, or something that you think of may not be top of the differential elsewhere. So epidemiology really guides wound care as well. So I will leave you with that message, and thank you very much again.
Thank you so much. Until next time, Dr. Sundareshan.